I just want to start with 2 or 3 transparency slides in order to show you the steps we follow to come up with a diagnosis when we look at a cardiac valve and the different possibilities we have in a very short and concise form. If we receive an aortic valve with a clinical diagnosis of aortic stenosis, the main thing, and that is something that we can't repeat enough times, is please keep the valve intact and inspect it from the aortic side. Cutting the valve is something that destroys the anatomy and sometimes makes it very, very difficult for us to determine what the etiology is. And this goes for all valves. The things we take into account are the number of cusps, the number of commissures, the presence or absence of commissural fusion, and the presence and the degree of calcification. Once we have put all these variables together, we try to come up with a cause for the stenosis. And I will follow these steps with you with every single valve we're going to look at. I want to try to start showing you a normal aortic valve, and before starting I ask Bob to be patient with me since I didn't train with him, so I probably will not use the same words he does. But this is a normal aortic valve. 1, 2, and 3 cusps, which are flexible, which move, opening completely, with no fusion of the commissures. Commissures are clean. There are no areas of calcification, and you can see that it closes opposing one aortic valve cusp completely with the other. And this will be important later on when we get to aortic regurgitation. So let's start with aortic stenosis. We are looking at an aortic valve from above, from the aorta. We count the number of cusps, 1, 2, 3, 1, 2, 3 commissures. And we can see that the main problem in this valve is the presence of huge deposits of calcium on the body of all 3 cusps. There is no fusion of the commissures, and that rules out post-inflammatory aortic stenosis. And we have 3 aortic valve cusps, so it's 3 cuspid, And with this amount of calcium in the body of the cusps is what I call senile calcific, which is a term Professor Becker doesn't really enjoy. If I try to put my finger through the aortic valve orifice, I can barely move the cusps. So you can see how stenotic this valve is. Let's look at another type of aortic stenosis now. This is another aortic valve looked at from above, and we can see that there is one cusp here and another one facing this one. So we have two cusps. The commissures are free. There is no evidence of fusion. And the striking feature in this aortic valve is that the two cusps are unequal in size. And the bigger cusp has a raphe, which is calcified here, and which is the main problem limiting for the limitation of the movement of this cusp. If I try to put my finger through the aortic valve orifice, you can see that the bigger cusp with the raphe moves barely and only in this small area where there's no raphe. And once again, there is significant stenosis. Now, what happens when we have a stenotic aortic valve? The left ventricle shows left ventricular hypertrophy of different degrees, and this is a transverse section of the heart of the patient with the bicuspid stenotic aortic valve I've just showed you. This is the right ventricle, the left ventricular cavity, the septum. You can see that there is concentric or diffuse left ventricular hypertrophy. And I want to refresh your memory briefly, although Professor Davis talked yesterday about rheumatic heart disease, regarding what we see in this entity. If we look at this aortic valve, we count the number of cusps, 1, 2, 3. We count the number of commissures, 1, 2, and 3, and we can see that the main feature in this valve is fibrosis in all three cusps with retraction and fusion of all three commissures, leading to a fixed aortic orifice. Now, although all these steps seem very reasonable and logical, we do not always manage to come up with a diagnosis. Some valves are quite difficult to interpret, and the percent of valves which go undiagnosed in quotes ranges from 1 to 5% in big series. I want to show you one aortic valve which will probably come up when we have the discussion. If we look at this valve, it has one big leaflet, and if we try to put it together, we can see that the orifice is elongated. Now, I can say that this is a unicuspid or unicommissural aortic valve, which is stenotic. But some of you might think, well, there are two areas here, which, if I think this is a unicommissural valve, I will say there are calcified raphes. If you think these two areas are not calcified raphes but fused commissures, you can say that this is a three-cuspid aortic valve, post-inflammatory as a cause of the stenosis. So we can leave this one aside for the time being and get back to it later on. Let's look at aortic regurgitation now. What are the variables we take into account to come up with a diagnosis? The first thing is there discordance between the cusp area and the root area? And that means, is the aortic root big, or are the cusps relatively small? And I will show you a couple of examples of enlargement of the aortic root resulting in aortic regurgitation. The other thing we want to look at are the commissures. We want to determine if they are widened, if they are distorted, or if they are unsupported, resulting in prolapse of one of the aortic valve cusps. And finally, bicuspid valves can result in aortic regurgitation, and we need to assess if there is any dilatation of the aortic root and how unequal are the cusps. I will show you now a heart with dilatation of the aortic root, which is pulling the aortic valve and stretching it, so that even if I try, I am not able to close the cusps. Another thing we look for, and which is present in all the cases of aortic regurgitation, is rolling or thickening of the free edge of the aortic valve cusps. And that is due to the blood flow going in both directions. This is another example of dilatation of the aortic root, you can see once again that there is mild thickening of the free edge of the aortic valve cusp, and if I try to push the cusp into the center of the aortic valve in order to make them close, I don't succeed because they have been stretched due to the dilatation of the root. And this is what the cusps look like. If what we get is a surgical specimen, we can see there are 1, 2, 3 aortic valve cusps. They are thin, transparent. There is no fusion of the commissures whatsoever, and they are slightly, only slightly, unequal in size. Now, going back to the point I made at the beginning, if you would cut one of these cusps in two, it would make, or possibly put the entire cusp through for histological examination, it might make life a little bit difficult when we come to the point of deciding what the diagnosis is. So we try to keep it intact and make our diagnosis based on the macroscopic appearance. Now, what happens with the mitral valve? If we come upon a case of mitral regurgitation, we need to look at the whole of the mitral valve as an entity composed of cusps, chordae, papillary muscle, etc. So let's go area by area or section by section and see which are the possibilities we have when we look at the mitral valve. If we're just looking at the cusps, they may be thickened and retracted, like you have seen Professor Davis demonstrate yesterday in rheumatic heart disease. The cusps can show expansion, which is what you see in floppy mitral valve or mitral valve prolapse, and the presence of a perforation points towards infective endocarditis. If we now look at the chordae, they may be shortened and fused if the case is rheumatic in origin, or they may be thinning or thinned and elongated, as you see in floppy mitral valve. Rupture of the chordae tendineae is seen in floppy mitral valve, in infective endocarditis, and occasionally it can be traumatic. look at the papillary muscles now. You can have acute mitral regurgitation with rupture of a papillary muscle. That happens in acute myocardial infarction, as was discussed yesterday by Dr. Mary Shepard, or also within the context of ischemic heart disease, you can have fibrosis of the papillary muscles resulting in mitral regurgitation. If we look at the mitral ring or mitral annulus, it may be dilated, as we see in patients with Marfan syndrome, and the dilatation of the ring in itself results in mitral regurgitation. Or we can have calcification of the mitral ring, which is seen in populations over the age of 65. And it's a very typical feature of finding in elderly people. And finally, the last element in this group is the left ventricle, or I should say the left ventricular cavity. If we are confronted with a condition resulting in dilatation of the left ventricular cavity and poor left ventricular function, we will have mitral regurgitation as well, because dilatation of the cavity will pull apart the papillary muscles and will result in dilatation of the mitral ring as well. Let me show you now a case of mitral valve prolapse or floppy mitral valve. This heart belongs to a 23-year-old healthy man who dropped dead suddenly. And if we look at his mitral valve, the posterior leaflet and the anterior leaflet, we can see that the leaflets are slightly thickened, whiter than usual, and that there is ballooning or hooding of both the anterior and the posterior mitral leaflets. The chordae in some areas are becoming extremely thin. And very much prone to rupture. If we look at the same mitral valve from the left atrium, we can see the typical ballooning of the mitral leaflet, and in a way it's like if the leaflet was sitting instead of being standing like it does in a normal heart. Patients with mitral valve prolapse may or may not develop mitral regurgitation. And when they develop mitral regurgitation, they will increase the size of the left ventricular cavity, of the left atrium, and they will become a high-risk population for infective endocarditis. However, the finding of ruptured chordae spontaneously without significant increase in symptoms or mitral regurgitation is not uncommon in mitral valve prolapse. Floppy mitrals are also seen in association with Marfan syndrome, and this is the anterior mitral leaflet of a floppy mitral valve in a patient with Marfan syndrome who also had infective endocarditis. If we look at the valve and forget about the perforation for a moment, we can see that it is glistening white, diffusely thickened by fibrous tissue. It has the typical ballooning or hooding. And if we now look at the evidence for infective endocarditis, we have an area of perforation here, which is all within or all contained by fibrous tissue, which looks relatively old, whereas next to it is an area of discoloration, tan-colored and bluish-colored, which is probably more recent. If we now look at the chordae, there is a small area of calcification here, which probably corresponds to an old vegetation which has calcified with time. And there are some small irregularities on these two chordae, which are also calcified and also probably are old vegetations which have calcified with time. After having seen the elongated and thin chordae of the floppy mitral valve, let me remind you just for a second of what shortened and fused chordae look like as we see them in rheumatic valve disease. This mitral valve, which has been split or open at one of the commissures, shows diffuse thickening. It's very white and glistening, and if we look at the chordae here, they are very short. We cannot distinguish one from another. They are just a mass of thickened, white, fused chordae together, inserting onto the papillary muscle or coming from the papillary muscle. There is another point I want to make looking at the valves, which is prosthetic valves, which is generally forgotten when we talk about valves or heart valves. And we can divide prosthetic valves into mechanical and bioprosthetic ones. The bioprosthetic ones are made with different materials. The most commonly used one is the aortic valve from the pig. And those bioprostheses are called either Hancock or Carpentier-Edwards, commercially speaking. and they are the most widely used all over the world. However, you can use other biological materials to make bioprostheses. You can use bovine parietal pericardium, which makes the Ionescu-Shiley bioprosthesis. And in the 70s, one prosthesis which became very fashionable, which was abandoned quite soon after having been used for only just 3 years, was dura mater, which, as far as I'm aware, is not in use any longer. So what happens with the bioprosthesis? We're using biological tissue which can show the same problems than a native valve. And the main problem with bioprosthesis is calcification. If we look at this bioprosthesis, it has a ring, which is the area where you suture it into the valvular ring. We can see part of the sutures here. And this ring becomes covered with fibrous tissue with time. We can see this here with fibrous thickening or fibrous growth covering the ring. So one thing we have to look for when we examine a bioprosthesis is that the ring is intact. The second thing to look for are the struts. If there is no mismatch between the size of the cavity or the annulus where the valve was inserted and the valve itself, or the prosthesis I should say itself, the struts are going to be at a 90-degree angle or only with a slight bend towards the center of the bioprosthesis. Whereas we have seen in cases of a bioprosthesis being too big for the cavity where it has been inserted, the struts bending and sometimes even producing hemodynamically significant obstruction. And let's now look at the leaflets. There are 1, 2, 3 leaflets with 1, 2, 3 commissures. And the pathology most commonly encountered with these valves are small deposits of calcium, mainly around the commissures and in the body of the cusp. And that increases stress locally and breaks the cusp when it bends open. All this bending mechanism results in tears, which is what we can see in this leaflet here, resulting in bioprosthetic regurgitation. We have another bioprosthesis here where you can see a small calcific deposit at this commissure, and right next to it there is tear, which I'm pointing at now. We generally call the process wear and tear, and the average life of a bioprosthesis is said to be between 10 and 12 years. However, there are instances in which the speed of calcium deposit increases like in children, and thus it's a contraindication to use bioprosthesis in children. But the other point to take into account is when we use bioprosthesis in postmenopausal women who are taking calcium supplement. We have seen 4 or 5 of those in, or I've seen them in the USA, of women who had valvular valve replacement and went on ingesting huge amounts of calcium and calcified their bioprosthesis in 12 to 16 months. I left one valve which I would like to discuss with Prof. Davis and Prof. Becker, but during the discussion time. I think that's it.